Hello, hi everyone. Welcome to Sri Academic Webinar Sessions. I am Dr. Paul Bright, Medical Officer Spine at LRH. Today I am going to be the moderator for session. Before going into the session, I'll try to tell a few housekeeping information. This webinar link will be open to join up to 9:45. No late attendance will be entertained thereafter. Each attendee is expected to stay and participate up to the end of the session so that they can get the certificate. This is to improve and maintain the standards of CPD program conducted by Shri. So thank you very much for strictly adhering with our CPD regulations and kind completion for your kind compliance. Today, let me introduce our resource person, Dr. Nirmal Marasinghe, who is an orthopedic surgeon spine at LRH. He is a proud product of University of Sri Jayawardenepura, and he had his MD from University of Colombo. He was trained overseas in different countries, namely UK, Ireland, and Australia. He is one of the vibrant, compassionate, and resilient orthopedic surgeon who the country retains so far. Let me welcome sir. Sir, over to you.
And as Paul introduced me, I'm Dr. Nirmal Marasinghe. I'm the consultant orthopedic surgeon at LRH. I'm taking care of spine surgery at LRH. So today's topic is the scoliosis. We are going to talk about a different topic, I think, about scoliosis. So let's move on with the presentation now. So basically, I'll be talking about what is scoliosis, type of scoliosis that we find, a little bit about the classification and progression of curves, as well as non-surgical management and the surgical management. So first of all, what is scoliosis? Now, scoliosis is a S-shaped deformity of the spine in the coronal plane of the body. Now, basically the angle of the curve has to be more than 10 degrees for us to classify it as scoliosis. And typically, a scoliotic spine has 3 curves. Now, if you can see this photograph of the X-ray, you can appreciate there are 3 curves there. So from in the thoracic spine down to T5, if there's a curve, we call it proximal thoracic curve. And then you get a main thoracic curve at the thoracic region. And if the curve progresses down into the lumbar area, then that curve is called either a thoracolumbar or a lumbar curve. So according to the SRS, or the Scoliosis Research Society definition, a thoracic curve is a curve which has the apex from T2 to T11, T12 disc level. And if the apex of the curve is at T12 L1 region, then that's a thoracolumbar curve. And below that, if the curve is below that, the apex of the curve is below that, then that's a lumbar curve. So a little bit about statistics. So 2% of children are affected at some stage of life, and 10% of affected patients will require corrective surgery. So basically, if you take the entire population under 16, about 1 to 3% of population will have some sort of scoliosis, but only 0.1% will have curves which are greater than 40 degrees. Naturally, girls are more affected than boys. And when it comes to severe curves more than 30 degrees, generally girls outnumber boys by 10 to 1. To understand what is scoliosis, we need to know a bit about the normal anatomy and alignment of the spine. So, as you all know, that our spine has 4 main segments: cervical, thoracic, lumbar, and the sacral region. And the cervical spine has what you call a lordosis, or curved anteriorly, where the convexity of the curve is anterior. And when it comes down to the thoracic spine curves the other way around, where the convexity of the curve is posterior. Then later on, the lumbar spine has a lordosis, and the fixed sacrum or the sacral segments are in kyphosis. And in these regions, cervical, thoracic, lumbar regions, the vertebrae, the anatomy of the vertebrae also differs from each other. But basically, any vertebrae has what you call a body, pedicles, lamina, and ends up with a spinous process. And so these pictures depicts the anatomy of the vertebral bodies or vertebra at each level. Now, when it comes to scoliosis, it's not a two-dimensional deformity. So it's basically a three-dimensional deformity. And there is, apart from the lateral angulation, there is also rotation. So if you take a normal spine in your APN, anterior, posterior, and lateral aspects, in the anterior posterior aspect, it will be straight, and the lateral aspect, you will observe the normal curvatures of the spine. But when it comes to scoliosis, in the anterior posterior view, there is angulation along the curves, plus there are rotation of vertebrae. So if you move on to the into this picture, then you can appreciate this is in the thoracic region. The vertebral body is also deformed. So it's not in the correct shape because of the rotation of the vertebra. And here the spinous process is also curved, and the transverse processes, they are also deformed. And you don't get equal sized pedicles on either side of the vertebra because of the deformation and the rotation. And especially when it comes to the thoracic spine, because of the rotation of the vertebra, the ribs which are attached to those vertebra also get deformed. So as they rotate, one side pushes upwards, thus forming what you call the rib hump, as you can see in this picture. So I hope you can see. Then there's a term called kyphoscoliosis. So if you take the normal spine, at the thoracic region, there's anywhere kyphosis, but this kyphosis is physiologically is from 20 degrees to 40 degrees. But beyond 40 degrees, we call it. Now, sometimes scoliosis can be associated with kyphosis as well as scoliosis. As you can see in this child, you see that the thoracic spine is also kyphosed beyond the physiological level. And if you take the posterior view, you see that the spine is curved like an ish. So here, both kyphosis and scoliosis coexist, and more often this is the case. So this is called kyphoscoliosis. But mind you, kyphosis can exist without scoliosis. Then to understand the curves and the patterns, we need to know a bit about common terminology that we use when you are talking about scoliosis. So first, what we get is what you call CSVL, or the center sacral vertical line. Now, just concentrate on this picture. So if you draw a line connecting the iliac crest horizontally and draw another line perpendicular to that, bisecting the sacrum like this, that is called the center sacral line. So that's basically the center or the alignment axis of the normal spine, right? So the next word that we use is what you call Cobb angle. The Cobb angle is basically the angle of the curvature. So as I said, scoliosis usually have three curves, and out of these three curves, each has Cobb angles. So Cobb angle is the maximum angle of the curvature, as you can see in this picture, which is shown in A. Then the term that we need to know about is what we call end vertebra. So end vertebrae are the uppermost and the lowermost vertebrae which contributes to each curve. So if you take this curve, this is the top bone or top vertebra which is contributing to this particular curve, and this one is the lowermost one. So this is the upper end vertebra, the one which is in superior, and this is the lower end vertebra. And apex, or the apex of the curve, is the vertebra which is deviated furthest away from the center sacral line and the one which is most rotated. So each curve will have an apex. So, but then what do we see clinically? So clinically, typically with scoliosis, we see several deformities. One is called the rib hump. So if you see this patient picture here, you see that the right side of the rib cage has come, has pulled upwards, so it has become prominent. So this is called a rib hump, and the rib hump occurs due to the rotation of the rib cage, as I showed in the previous pictures. Then they would get what you call a shoulder imbalance as the spine curves in the coronal plane. Usually one shoulder goes up and the other one goes down. Like you see that the shoulders are not in the same plane. Then one would get what you call a trunk shift. Now, what you see, the line here is the center sacral line or the center of the body, but then the trunk has shifted away from that line. So this is called a trunk shift. So to compensate the pelvis, the shoulder imbalance as well as the trunk shift, usually the pelvis also tilts. So this is called a pelvic tilt. So here you see that the left side of the pelvis is situated superiorly compared to the right side. And also you can get coexisting kyphosis along with scoliosis. So when it comes to clinical assessment of scoliosis, then there are certain things called red flags. Red flags, when you see something red, that means danger. So when you encounter someone with scoliosis, we need to look at these red flags to see whether there is anything unusual going on apart from scoliosis. So the first thing that we come across is what you call a left thoracic curve. Now, usually the main thoracic curve or the apex of the main thoracic curve would be on the right side of the patient. So that is the usual scenario. But however, then we come across curves where the apex of the curve is on the left side. Sometimes it could be harmless. Sometimes it may be due to some other pathology which is going on apart from simple scoliosis. So if you encounter a left thoracic curve, that means that requires further evaluation. Next thing is pain. Now, scoliosis and the progression of scoliosis is a phenomenon which occurs with growth, and usually it doesn't give rise to pain. So often children come with complaints of some sort of pain. Most of the time they are mechanical, but if the scoliosis is directly or actually associated with pain, then that's something alarming which needs urgent attention, because that's not the usual scenario. So normal scoliosis doesn't actually give rise to pain, right? Especially at younger age. Again, then if someone has some sort of neurological deficit, so if there's a neurological deficit, then that's a red sign or red flag, which needs to be further evaluated urgently. And because that means there's some compromise or some danger into the neural elements because of the scoliosis, or there's some other pathology going on which is unusual for normal scoliosis. Then we often come across neurofibromatosis patients, and we need to think of family history of neurofibromatosis, or as you can see in this girl, there are multiple caffeolate spots in this girl. So features of neurofibromatosis, those things we need to see in our clinical assessment. So next thing in the clinical assessment is that we need to find out whether the curve is a structural curve or a non-structural curve. So structural curves are stiff curves which becomes prominent, and the way to find it out is what you call the Adams forward bending test. So when you ask the child to bend forwards, if it is a structural curve, it becomes more prominent, as you can see in this picture. In normal spine, when you bend forwards, if it is a non-structural curve, it straightens out and you won't be able to see any prominence. The other thing that we need to find out in clinical assessment is whether there is a leg length discrepancy. Leg length discrepancy means one leg is shorter than the other. And because of the shortness, the pelvic naturally tilts to compensate that. And thus, the spine also curves along that. So, if there's a leg length discrepancy, when we correct the leg length discrepancy, like in this picture, the spine straightens out. So, a little bit about non-structural scoliosis. So, non-structural curves are reversible lateral curves of the spine that tends to be positional or dynamic in nature. So, in non-structural curves, there is no rotational changes in the vertebrae. So, it will be just lateral curves. And when you adjust the position or when the patient goes into either supine or prone or sitting positions, these curves disappear. So correction of the lateral curve in non-structural scoliosis is possible with forward bending, like in the Adams forward bending test, by positional changes of the spine or the pelvis. And sometimes you can get non-structural scoliosis due to muscle contractions. So when we deal with the muscle contraction, the spine straightens up. And also, as I told you before, if there's a leg length discrepancy, once you correct the leg length discrepancy, the scoliosis disappears. So these are called non-structural curves. It could be further classified, the non-structural scoliosis, into postural, compensatory, sciatic, inflammatory, and lastly historic. So postural curves, these curves are due to prolonged use of wrong posture, and it resolves when the child lies down. So once the posture is corrected, the scoliosis goes away. Compensatory is due to leg length discrepancy, as I told you before. Now sciatic in the sense, now if you get pain along your sciatic nerve, either mostly due to either disc protrusion or any compression at the nerve root level, the body naturally turns to one side to avoid pain. So because of that, you see there's a curve in the spine. So once you deal with the pain and the sciatica, these curves or the scoliosis disappears. So this is called sciatic pain or sciatic scoliosis. The same scenario can occur with inflammation caused by infective processes like appendicitis or psoas abscesses likewise. So they also can have a curve in the spine, which resolves with once you sort out the inflammation. Very, very rarely there can be psychological and component associated with them, where historically they tend to be onto a side or they're like scoliosis, but then these are not structural curves. So once you see someone with scoliosis, naturally we need to take an X-ray, but there's a special X-ray called full spine orthogram, AP and lateral. So orthogram actually can incorporate the entire spine, as you can see in this X-ray. Yeah, you can see from C1 down to pelvis. Normal cassettes or X-ray radiographs will not be able to capture this amount of length in the spine. But for assessment purposes for scoliosis, we need what you call this orthogram, right? And this orthogram is useful to assess severity, and we can measure angles. You can see that in this X-ray that we have measured the angles in this X-ray, and also to follow up to see whether this is progressing or not. So we take serial X-rays to see with time to time to see whether the curves are progressing. So this orthogram is very important in that aspect. So apart from that, we can get what you call bending films, especially when we are planning a surgery for this patient, to see how flexible the curves are. So, and the X-rays are also useful to assess bone age, which is quite important in management of scoliosis, because scoliosis is a disorder which is associated with growth. Then sometimes we need to get a CT scan And the CT scan will show us the exact bony abnormality, whether there are formation and segmentation defects. And also it's useful to measure the sizes of the pedicles, which is more necessary when we are going for surgery. And at times we need to get an MRI scan of the spine. And that is basically to assess an entity called spinal dysraphism. That means problems which are associated with the cord. So often scoliosis could be associated with what you call cord tethering. Cord tethering in the sense the terminal part of the spinal cord, what I call is actually attached, physically attached to the lower part of the sacrum. So as the child grows, because of this attachment, it does not allow the cord to grow along with the spine. Thus, this can cause a neurological deficit as the child grows, as well as if you are going for any surgery, when you are correcting the curvature, the spinal cord stretches because of this, and it can cause neurological deficit. And that's what you see in this first picture. And as you can see in the second picture, this is called a syrinx or syringomyelia. This could be associated with scoliosis. If there's a syrinx, then of course it needs to be monitored regularly to see whether it expands. And if it is expanding or causing neurological deficit, you need your neurosurgical colleagues to deal with that. Then, very rarely, but we have seen it, is called diastomatomyelia, where the cord is actually not has bisected, or it's in two different has bisected into two, like you see in this X-ray. So the cord can be this is a formation defect of the spinal cord, and the division can be through a fibrous septum or sometimes a bony septum. So if such deformity exists, when you are correcting the spine, either with either surgically or non-surgically, it can cause compression and stretching of the cord. Thus, and the child can end up with some sort of neurology. So to find these sort of abnormalities, one would need to do an MRI scan of the spine. So the next topic. So we need to know the types of scoliosis, right? So they can be classified into two ways. Like first is chronological in the sense the time of occurrence. So chronologically, we can divide them into infantile, juvenile, early onset, adolescent, and adult. So I think that's self-explanatory: infantile, juvenile, early onset, adolescent, and adult. Then another way of classifying them is what we call etiological. Etiology in the sense the cause. So it can be congenital from birth. It could be due to neurological problems. Idiopathic in the sense we don't know what the cause is. And later on in life, due to degenerative process in adults also, you can get scoliosis. Let's move on to congenital scoliosis first. So congenital scoliosis, so as the name implies, it occurs from birth, and they are due to formation and segmentation defects of the spine. So they can have what you call hemivertebra, butterfly vertebra, unsegmented vertebrae, sometimes bony bars, and there's entity called spondylocostal dysostosis, where the vertebra as well as the ribs, they are abnormal. And sometimes you can get what you call congenital spondylolisthesis, where one vertebrae slips over the other. So these are the deformities that we see in congenital scoliosis. So those entities are explained further in these pictures. If you move on to this top picture, So that shows failure of formation. So here you get what you call a hemivertebra. That means only a part of the vertebra is formed properly, but there's a disc all around it. But then, so one side of the vertebra is not there. So because of that, it's like a wedge. Then you can get a different variety of that, where there is a hemivertebra, only a part of the vertebra is there, but then it's fused to the upper part or the lower part of the vertebrae. So this is called a fused hemivertebra. Then this is the other segment, which we call failure of segmentation. So as the spine segment into individual vertebrae, there's a defect there and they don't segment properly. So one can get a what you call a block vertebra. Number of vertebrae are there as a block and they haven't separated at all. Then you can get what you call a bony bar. Only one part of the or one side of the vertebrae are separated, but the other side it's not separated. It's connected by a bony bar, and the bony bar can coexist with hemivertebrae also. And the lower picture explains the failure and these deformities further. And in this picture, you see that this is a semi-segmented vertebra. So basically, there are hemivertebrae. They are not completely segmented from the vertebrae above and below. So you can see that this particular hemivertebra is separated from the vertebrae below, but it is attached to the one above. But then you can get what you call a fully segmented hemivertebra. So it's not attached to either the top or the bottom vertebra. Then you can get what you call an incarcerated hemivertebra, which is again a hemivertebra, but it is attached both to the top and bottom vertebra. Then the next entity is what you call a wedge, and it's attached to the as you can see in this picture, it's attached to the top vertebra, but not the bottom one. But then it goes further beyond the midline of the vertebral column, and it's rather than a hemivertebra, it's a wedge vertebra. When it comes to failure of segmentation, you can get block vertebra, unsegmented bars, and then you can get the mixed picture, unsegmented bar with hemivertebra. Hope that's not too complicated for you. So congenital scoliosis could be associated with a lot of syndromes actually. So it can be associated with vectoral deformities, and as well as some syndromes. You can see in this chart, Marfan syndrome, Ehlers-Danlos, the connective tissue disorders, muscular dystrophies like Duchenne, osteochondrodystrophy like dwarfism, neurofibromatosis, Noonan's, Engelmann, Rett, Prader-Willi, and also osteogenesis imperfecta, and also Down syndrome. So there are a number of syndromes and congenital problems which can give rise to scoliosis. The next entity is what we call neurogenic scoliosis. Now, in these children, scoliosis occurs due to neurological problems. For example, cerebral palsy. A lot of patients with cerebral palsy end up with scoliosis. Meningomyelocele, naturally, there's a defect in the formation of the vertebra also. And as they grow older, they get deformities of the spine, scoliosis as well as kyphosis. You can see in this picture, in this child, the meningomyelocele has been operated, but later on they develop deformity of the spine. Then often children who has had encephalopathy, hemiplegia, those sort of diseases later on end up with scoliosis. Hereditary sensory motor neuron disease, seizure disorders, and muscular dystrophies like Duchenne. All these problems comes under neurogenic scoliosis. So these children needs to be followed up for longer periods because of the chance of developing scoliosis later. Now, the commonest type of scoliosis that we see is what we call idiopathic scoliosis. Idiopathic scoliosis, as the name implies, we don't know the cause for the deformity. And if it occurs in less than 3-year-olds, we call that infantile. And if it is in patients with less than 10 years, it's called juvenile or early onset. And usually, majority of the patients that we see are in the adolescent age. So we call that adolescent idiopathic scoliosis. So we don't know the actual cause for the reason for the scoliosis, but we think that probably multiple contributing factors are there. And there's definitely some genetic predisposition, but it's not consistent. That just because someone in the family has scoliosis doesn't mean that everyone else is going to get it. But then there are associations where you see family history of scoliosis in certain patients. So there is a discrepancy of muscle excitatory potential on either side of the spine. Basically, there's a muscle imbalance on either side of the spine of these patients, and we don't know why. 30% of them has vitamin D deficiency, but then correcting vitamin D is not going to straighten the spine. So, as in any medical condition, scoliosis also has a classification. So, King classification is the earlier classification, which is much more simpler. So, from 1 to 5, and it goes according to the type of the curve. So, 1 is a double curve where the lumbar curve is bigger. 2 is again double curve where the thoracic curve is bigger. 3 is the main curve is the thoracic curve. The lumbar curve stays in line. When it comes to 4, both lumbar curve and the thoracic curve is away from the center sacral line. And when it comes to 5, you have 3 curves. So that's the King classification, which has been there for a long time. And it's much more simpler. But nowadays, what we use for scoliosis management is this classification called Lanka classification, which is much more extensive and goes into detail. And you have 6 subtypes of Lanka, and those are divided according to the structurality of the curves. The 3 main curves: the proximal thoracic curve, the main thoracic curve, and the thoracolumbar curve. And according to that, you get 6 types. And this particular classification takes into consideration the kyphosis of the spine, as well as whether the deviation of the scoliosis, scoliotic spine away from the midline. So all 3 elements are taken into account when making this classification, which is quite important to us when it comes to planning surgery for these patients. The most important question when it comes to scoliosis is progression. So progression of the curve. Now, what we need to understand is naturally the curve progresses as the spine grows. Certain children have very rapid growth, very rapid progression of the curve, whereas some are slow, and we don't know why. We don't know why one is going to rapidly progress, the other one is not. So when it comes to management of scoliosis, so it's a race between the spinal growth and the curve progression. So we need to allow the spine to grow, because otherwise the child is not going to achieve adequate height. at the same time contain the progression, because as the child grows, as the spine grows, the curve is also going to progress. So at bone maturity, if the curve is between 30 to 50 degrees, the chance of progression is about 10%, and they progress about 10 to 15 degrees over lifetime. If the curve is beyond 50 degrees, it is bound to progress even in later into life, at least 1 degree per year. Let's say a child is at 50 degrees at 15 years. When he becomes 25, the curve will become 60. So at bone maturity, if the curve is less than 30 degrees, the data supports that there is not going to be any progression. So if we can find, or if we can identify a curve less than 30 degrees in a child, so our goal should be to somehow keep it under 30 degrees. If the curve is beyond 90 degrees, there is increased risk of life-threatening effects on pulmonary function. So, therefore, assessment of the growth potential in a child is very important. So that determines one of our endpoints, where the child has grown adequately, whether to see whether there is chance of curve progression. So age is important, of course, right? Age is important, especially when it comes to adolescent idiopathic scoliosis. If you take girls, usually by 14, 15 years, they achieve bone maturity. Whereas in boys, of course, we know that they grow up to about 16, 17, sometimes as up to about 18 years. One of the things that we go by is menarche in girls. So usually by about 2.5 years of after menarche, we achieve bone maturity. But menarche can be a bit tricky. You have to take history in detail, especially when it comes to premature puberty. Right? Sometimes parents claim that that the child has achieved menarche about when they are around 8 years, 9 years, or sometimes even earlier than that. But if you ask them, they probably would have had a single episode of menstruation, and afterwards they haven't had any menstruation for good 2-3 years sometimes. So basically, we can't take that particular point as menarche. So that's not a physiological entity. So basically, we have to determine when the child actually has had proper puberty or menarche, right? So that's something that we go by. So if the child is in pre-menarchal or region, so mother's menarche or mother's age at where the mother has achieved menarche comes into play, because usually girls achieve their puberty menarche around where their mothers have had their menarche. So that's something we also go by. Then more objectively, we can have a look at the Tanner stage to achieve whether they are in puberty. And we generally expect the second generation to be taller than the first generation. If it's a girl, whether the child is taller than the mother. When it comes to a boy, whether the child is taller than the father. So if they are close to their mother's side or father's side, that means they have achieved adequate height. Then also with the X-rays, we have a look at the growth plates, the apophysis of iliac crest, irradiate cartilage, as well as olecranon to see whether they have achieved bone maturity. So bone maturity in the sense the bones doesn't grow anymore once the physis is closed. So one of the commonest things that we look at is what we call the riser grade. So when you take an orthogram of the spine, you can have a look at the pelvis also at the same time. This is not the most consistent way of looking at bone age, but this is something that we can easily see in when you are taking X-rays for the spine. So riser grade is the closure of apophysis of the iliac crest. So it starts from anterior to posterior and appears in 4 stages. So when the apophysis appears in front, it's 1, 2, and as you go on, as you can see in the picture, it comes in 4 grades. And once the apophysis is fully fused or integrated into the iliac crest, it's called riser 5, and it's generally associates with bone maturity. Little bit about non-surgical management. Now, non-surgical management is for smaller curves, and non-surgical management is important to buy time sometimes if the child requires surgery but is not in a state or old enough to do any sort of surgical intervention. So till then, we have to manage them non-surgically. And if the child is not at all a candidate for surgery, then there's no other way, but we have to manage them non-surgically. So there are different methods of managing non-surgically. When it comes to less than 5-year-old, there is a method called Mehta casting, as you can see in this picture. That's called traction, applying traction and casting them. So this is a form of serial casting, hard cast, and we have to replace that every 3 months. As you can see in this picture, there's a special apparatus called Mehta apparatus, where you can put traction safely whilst it allows us to put a cast into the chest. And generally, these are done under general anesthesia. And this is a system developed by, of course, Mehta. And for less than 5-year-old, this is a very effective way of controlling spine progression, curve progression, and they generally tolerate it. But of course, there are complications. You can get skin abrasions, dermatitis, pressures also associated with the cast, and very rarely breathing complications where you need to take the cast off. And mind you, this cast is going to be there for 3 months at least. And bathing and managing the child's hygiene is sometimes a bit difficult with this casting. Here, of course, what you do, this is at LRH. We don't have the proper Mehta apparatus, but what we do is a table which is improvised, but we have achieved good results with that. So, and this is the cast that we put at LRH. So, next modality of non-surgical management is, of course, bracing. Most people must be aware of that. So we put hard braces around the chest, around the trunk to control curves. But mind you, now this is very important. This brace is only there to control curve progression. And the application of brace only till child has achieved bone maturity. Once they have achieved bone maturity, there is no use of a brace. Like sometimes you see certain children or are in braces even into their 17s, 18s, and even when they are at 19 years old. But actually, the brace is not doing anything for them apart from being cumbersome for them. So that is only for children who have not achieved skeletal maturity. The other thing is the brace cannot straighten the spine. So brace is only there to control curve progression, further progression, right? You can sometimes see a 5-degree or 10-degree improvement in the curve, but that is not the idea of putting the putting the brace in the first place. So basically to prevent curve progression. And sometimes you have to apply a brace to buy time in the sense the child would need surgery at some point, but if they are not in a suitable position to do the surgery, we'll put them on a brace to prevent the curve from progression so that the severity of the curve will be less by the time we get them to theater. Mind you, the brace also has a brace efficacy. It's about 60 to 80%. And the brace works more with thoracic curves than lumbar curves, naturally, of course, because the rib cage is there around the thoracic curve, and you can get a better 3-point fixation on the thoracic curve than the lumbar curve. And the brace efficacy gets lower with obesity. So in obese children, it's difficult to maintain the curves with bracing. And the brace has to be worn at least 23 hours per day, right? So if the brace compliance, this is the biggest problem. If the brace compliance is poor, the curve will progress. So these are two types of braces which are available. So this particular brace is called a Milwaukee brace. We don't use that in Sri Lanka actually. So what we use here is what we call the Boston brace. This picture shows a leather brace which is made at a LRH workshop, and also you can use plastic to make the same sort of brace. So these two are the plastic and the leather one. They are available in Sri Lanka, and it works well. Now, this particular chart shows what the action that we need to take. So if the riser grade is 0 to 1, if the curve is less than 20 degrees, we can observe. We don't have to brace. Again, if the riser grade is 0 to 1, but the curve is beyond 20 degrees, we have to put a brace. When it comes to riser 2 to 3, 0 to 30 degrees, still we can observe riser 2 to 3 in the sense the child has matured a bit. So the remaining growth is less. So even up to 30 degrees we can observe, but beyond 30 degrees, of course, we have to brace. So riser 0 to 3, 40 to 50 degrees. So it's a bit of a gray area. You can either observe or brace, but in our practice, we naturally put a brace on there. And 0 to 4, riser 0 to 4, still, if it is more than 50 degrees, best manage with surgery. As I told you before, there are sometimes child is not suitable for surgery, and especially when they have severe neurological deficiencies, like these children, like cerebral palsy, hemiplegic, those sort of children. They would benefit with what you call a specialized wheelchair. Now, this wheelchair you can see in this picture, it supports the child in upright position, and it supports the trunk with supports on either side of the spine. So basically, it's like a brace that they are using whilst they are on the wheelchair. So these are called specialized wheelchairs. In certain occasions, when they are not suitable for surgery or bracing, because the bracing becomes even more cumbersome to manage them for the patient as well as the carer. So in those situations, a specialized wheelchair is the best way to go forward. So this is, of course, a commercially available wheelchair, which is wheelchair, but these wheelchairs are made in Sri Lanka, not as luxurious as the other one, but then it serves the purpose. Then the role of physiotherapy. Now, this is also something most people get carried away with sometimes. Physiotherapy actually helps muscle strengthening and gait and balance, but is mostly important when the child actually comes out of the brace. Now, when as you were now, I told you that bracing is only till bone maturity. So once a child has been on a brace for a couple of years, usually the back muscles also becomes worsened and less in strength because of disuse. So they cannot be taken out of the brace all of a sudden because the muscles are not going to support them. Therefore, we have to wean them off the brace, and at the time of weaning off the brace, you need physiotherapy to strengthen the muscles. Otherwise, the curve will progress. But physiotherapy cannot straighten the spine. And in active scoliosis management, there's no role for physiotherapy apart from the time that they come out of the brace. Now, if a child is on a brace, as you know, it has to be worn 23 hours per day. And if you're going to take the brace off for various reasons, physiotherapy, exercises, etc., you're going to lose compliance with the brace, which is the most important thing in managing the curve. So therefore, physiotherapy has very limited application when it comes to scoliosis management. So lastly, we'll move on to surgical management. Now, if it's a hemivertebra or a deformity, a congenital deformity, so by about 5 years, if it is a single hemivertebra, of course, we can remove the hemivertebra surgically and fix it. Now, if you can see in this picture here, this is a hemivertebra, and surgically that hemivertebra has been removed and the segment has been fixed. So once that segment has been fixed, that fixed segment will not grow in height, but the rest of the spine will continue to grow straight. So that's the idea of doing the surgery there. But if there are multiple hemivertebrae, of course, or multiple congenital deformities, this is not possible at the age of 5 years. So less than 5-year-old, of course, it's difficult to do any surgical intervention because the vertebrae are very small. We can't put any instruments or screws into the spine. So 5 years is the earliest I think we could do an intervention for these children surgically. So pre-pubertal or less than children around 10 years, there's a method called growth rods. So as you can see in this X-ray, we have put screws and rods into the spine, but they are connected with a domino in the middle. So we can use this method where every 6 months we do a smaller surgery and distract these rods so that the child's spine grows in length. Otherwise, if you fuse them by 10 years, they will not have adequate spinal growth. So this is called growth rods. So this is something that we do in Sri Lanka. And we do serial distractions, and at the end of distractions, in the sense when the child has achieved adequate height, and when they are close to bone maturity, we can either do a definitive surgery and fix them later. So basically, growth rods allows us to maintain height whilst controlling the curve. So in developed and other countries, there is a similar method called magnetic growth rods or magnetic growing devices, where instead of this sort of growth rod, here they use a rod which can be elongated by applying a magnetic force from outside. So if you can see in this picture, so initial surgery was done, but later on, every 6 months, just by applying a device from outside of the spine without cutting into the skin, you can elongate the spine. And this can be done at outpatient level without any analgesia or without any anesthesia. So very convenient way to do it. But this technique has been there for more than, I think, 15 years now, but it's still too expensive for us to practice in Sri Lanka. Then we move on to definitive surgery. So definitive surgery, there are few approaches. You can go from anterior. Anterior in the sense you do a thoracotomy and approach the spine from anterior aspect, or you can do all posterior, and sometimes you have to combine the anterior as well as posterior approaches, right? So but then definitive surgery can be done only after adequate bone maturity, because it's going to stop the spine from growing anymore. So usually we do it for children after puberty. And when it comes to neurogenic scoliosis, so neurogenic scoliosis, scoliotic patients cannot be managed with growth rods. So if you are doing a surgery for a neurogenic scoliosis, you have to do a definitive surgery then and then. And we offer surgery for more than 55 degrees because the benefits outweighs the risk of surgery. But then from 30 to 50 degrees also, if the patients are willing, they can do surgery. So this is a picture of anterior approach to the spine. So they have done a thoracotomy and approached the spine from anteriorly. And you can see in this X-ray, so you put screws and rods into the vertebral bodies and straighten them. So this is a picture of posterior correction of scoliosis. You can see that you have opened up the spine from posteriorly, and we put screws into the pedicles and rotate the spine into place. So you can see in this X-ray where this girl has a 84-degree curve in the thoracic, the main thoracic area, and a 78-degree curve in the thoracolumbar area. Both curves have been addressed with posteriorly with screws into the pedicles and rods. And especially in children who has much more growth potential remaining, there is a way of controlling spine growth or spine curvature being progressing by doing what you call VBT, vertebral body tethering. So this is a form of growth modulation where this can be done in a minimal invasive manner with thoracoscopic approach, where you put screws into the curve and bind them with bind them together so that as the child grows, one side of the curve or the convexity of the curve doesn't grow because of the screws in this area. And the concavity outgrows the convexity, thus straightening the spine. So this is the uh, idea of doing vertebral body tethering. So this particular method has been becoming increasingly popular again. But this needs thoracoscopic approach. Plus, there has to be adequate amount of remaining growth in these children, so for the spine to straighten on its own. When it comes to very severe curves, especially curves which are now more than 90 degrees, one would need what you call halo traction, where you put traction onto the skull and keep them so that the spine becomes more flexible for us to operate. And it also reduces the chances of neurological accidents. And sometimes you have to do anterior and posterior approach both to address these severe curves, and then vertebral osteotomies. And the osteotomies, in the sense you have to remove parts of the bone to get them straight. Complications of surgery, main problem is paralysis. That's the dreaded complication that we are worried about. So, of course, death can occur, but then just 1% chance of paralysis in these children. It could be temporary or permanent, but this is something that we warn the patient as well as the parents before we embark on surgery. You can get bleeding, massive transfusion, and which is going to end up in massive transfusion, sometimes DIC. And there are certain complications that could be associated with prone position, blindness, strokes, etc. So there are a number of complications that you can get during surgery, but they are all very rare. Lastly, this is the one before the last slide. So general information about surgery after scoliosis. General recovery is about 6 weeks. We do not advise them to lift heavy weights, and we ask them to avoid contact sports because there's a chance of screw breakages, implant breakages. And these implants for life, we are not going to remove them unless like there is a complication like infection or something like that, because you have to do a separate big surgery to remove all those implants. So that's something that parents usually ask. So these implants work for life. And once you fuse the spine, in later on in their life, they cannot undergo spinal anesthesia because the spine is fused. And if it is less than 30 degrees, we don't do surgery. 30 to 55 degrees, only if the patient insists that they want to get surgery, because it's going to be purely a cosmetic surgery. But we do consider them if they insist. But more than 55 degrees curves are best managed with surgery. Lastly, I think these are certain things that parents, patients ask from doctors, whether the school bag is responsible. Often they try to put the blame on the school bag, which is not. School bag is not going to either affect progression or cause scoliosis. They are not lifting weights. Sports are not contraindicated in scoliosis. They can engage in whatever they want to do. Spine is stable, and the sports are not a contributory factor to for curve progression. Thus far, native treatment has no proven evidence of managing these managing scoliosis. And the other thing is, they do not have to sleep in flat surfaces. So the normal mattress is okay. They can sleep whatever they want to and whenever they want to. Right. So these are some of our success stories. Thank you. Sorry, I've taken a little bit more time than I've anticipated, then I'm open for questions.
Thank you very much, sir. Time for question and answers. Participants have sent some questions. I can most of them are covered with a lecture. I'll read out the questions which the audience may need some clarifications.
Yeah.
The impact of scoliosis in sports performances. They have asked about that. And shall I read out everything together and
Yeah, sure.
considering the time factors? And scoliosis, they have asked about the scoliosis management in patient with cerebral palsy and place of physiotherapy in scoliosis.
Right. I think I've finally touched on that. So basically, when it comes to progression of the curve, or sports as a causative factor for scoliosis. So sports doesn't cause scoliosis, and engaging in sports is not going to worsen the curve. But if you have put a child in a brace, sometimes they might not find it easy to do any sports with the brace. As you know, that brace has to be there for 23 hours per day. So certain sports they might not be able to engage in whilst on the brace. That of course we can't help it. But if a child is already engaged in some sort of a sports by the time that we have decided to put him on a brace, we can allow them to do sports removing the brace about 1 hour per day. But the remaining time, the brace compliance has to be absolutely perfect, right? So what I tell my patients, right? So if they are playing netball or something, if they are only playing for about 2 or 3 days per week, they can remove the brace at the time of starting practices. So if they are starting practices at 2 o'clock, they can remove the brace at 2 o'clock. And the moment they have finished practices, regardless whether they are sweaty or tired, they have to go back on the brace, and they can't come home and put the brace. They have to put the brace then and there at the field and come back home. And if they can maintain that sort of discipline, then we can allow them to do sports with that. And most children who are very keen on sports actually agrees with that and do that properly. So they are not losing time on their sport. They are managing well, but at the same time the brace compliance is also maintained. So with that sort of discipline, we can allow them to do sports. We just because they have scoliosis and because they are on a brace, we can't. It's not justifiable that they take their childhood away from them. So we do not advise any parents to stop dancing or putting the child to any kind of sports just because of scoliosis, but they have to absolutely maintain the brace compliance. So that's regarding sports. And physiotherapy, of course, I think I have touched on that extensively. I did not to speak about that again. And the other question was what was the other question?
Scoliosis management in children with cerebral palsy.
Yeah, now that's actually a very tough task, because these are neurological deficiencies which are causing scoliosis. Often these children have other problems, but so if they are it depends on the mobility and the condition of the child. Certain cerebral palsy children are hardly able to keep on a chair, right? If they are mainly bed bound, or if they are finding it difficult to maintain posture in a chair, right? And most of the time they have other breathing problems and difficulties. That sort of children are best managed with a specialized wheelchair, because if we put them on a brace, it's going to be even more difficult for them to be managed. And so we cannot do anything further for them. But children who have relatively good cognition, who are able to walk, can be managed as any other scoliosis, initially with braces, and if necessary, we can do surgery for them, right? And children with cerebral palsy, again, who can maintain their sitting postures, but they are having smaller curves, can be braced and managed as any other scoliosis. But special problem occurs when their cognitive function is difficult, where bracing is difficult, as well as they are not conducive enough for any sort of surgery. In which case, we resort to manage them on a wheelchair.
And there is another question, sir. They have asked regarding the preventive measures can be taken to prevent scoliosis in children with neuro disability.
So preventive in the sense, sometimes the neurological deficit may be due to muscle imbalance, right? So basically what we do is we monitor them. So naturally, you might know that we do get patients with cerebral palsy, meningomyositis referred to our clinic, who actually don't have significant scoliosis. But just because they don't have significant scoliosis at that time doesn't mean that they are not going to develop scoliosis later on in their life, because we know that majority will develop some sort of spinal deformity later on in their life. So these children needs to be monitored routinely and frequently. And if we find out that there's some progression in their curves, then they need to be appropriately managed with bracing. But there is no such way to prevent them from having scoliosis. So even when it comes to bracing, we are not going to jump and do any intervention on them, because whatever we do is going to hinder their normal day-to-day life as well as their mobility. So we observe them at least up to about 20 degrees before we embark on bracing. But there's no conclusive way of preventing scoliosis, especially in neurologically affected children.
There are a few technical questions like selecting the end vertebra of the curve and explain what is the in 3-point fixation of spine, like that.
Right. So can I move on to my presentation? Oh. Right. I hope you can see this picture. So if you take this picture, if you take this curve, the topmost vertebra which is contributing to this particular curve is the upper end vertebra. Now beyond this, the curve turns the other way around. So the proximal thoracic curve is this way, where the apex is on the, let's say this is right side, left side, this is on left side, whereas, oops, right, and right, right, and here when it comes down, this particular vertebra is the last vertebra which contributes to the thoracic curve. So that becomes the lower end vertebra. And beyond that or below that, the curve is to the other side. So these are the two end vertebrae, right? And if someone is asking about how we are uh, choosing which vertebra to instrument, what you call the upper instrumented vertebra and the lower instrumented vertebra, I think that is bit beyond the scope of this lecture. So that is bit too technical to explain now, to say to tell how to choose which vertebra to instrument. But then if the question is about the upper and the lower end vertebra, this is how we choose that. And what was the other question?
3-point fixation, to explain about 3-point fixation.
So 3-point fixation. So basically, if you take the same curve, now to straighten this curve, you have to put pressure from at the apex level. In this particular curve, the curve is the concavity is on the left side, the convexity is on the right side. So you have to put pressure at the apex on the right side to straighten the spine this way. But when you push the curve this way, for that to straighten out, you need two fixed points at upper and lower level of the curve. So it has to be fixed here at this level, and it has to be fixed here at this level, and there has to be pressure from this area. So you can see from now, these arrows are actually not meant for that, but then that nicely works for that also. So you need to have fixation here, and it has to be pressed from right to left, like that. So those are the 3 points which fix the curve. So that is what we call 3-point fixation. Like in any plaster or cast that which is applied to a fracture or something to straighten it. To straighten the spine also, you need 3-point fixation. So when you are applying casts, we use this method, as well as when you are putting a brace, inside the brace, there are padding which supports these 3 areas and presses the curve to make it straight. So that's the 3-point fixation. Paul?
Finally, sir, there is another question. They have asked about the complications associated with scoliosis correction and the success rate in Sri Lanka.
So complications wise, I think I have told you about the main complications. There are a number of complications that can occur, as in any other surgical method. You can get anesthetic complications, you can get complications due to positioning, bleeding, infection. Then there are late complications, like you can get complications with fusion, rods being broken, screws being broken. Those sort of things are there. But the main problem that we encounter or we are worried about is paralysis. So that's about 1%. And bleeding. And there are occasions where even death is reported, right? But then they are very rare. Success rate wise, it's like this. Now, for a long time, scoliosis surgery, in the past, we didn't have major centers to do scoliosis surgery. Only a few eminent surgeons were engaged in doing scoliosis surgery. But then, because of other facilities as well as time constraints, the number of surgeries which were done in Sri Lanka was not very they were not able to do it continuously, like continuous scoliosis management. Now, of course, things have changed. We have moved on from Harrington rods to wire fixations into pedicle screw fixations later on beyond. Now, the chances of complications have become less, and corrections have been better. And nowadays, of course, success rate is quite good. And since the installment of spine unit in LRH, now we have done 75 scoliosis corrections since 2021, sorry, and for the last 2 years. And we've been doing it continuously, at least one case per week. And we have had very good success with those surgeries.
Thank you very much, sir. I think we can wind up with that.
Yeah. Right. Thank you very much for having me. Hope this lecture would have made life.
Please fill the forms, Google form for your e-certificates, and which will be sent to your email address. Once again, I thank Dr. Nirmal Marasinghe for sparing his valuable time and enlightening us on the scoliosis correction and management strategies. Thank you, sir.
Yeah, thank you very much, Paul. Thank you, Sri, for inviting me for this. Thank you.